Okay, hello everybody. Welcome to today's webinar. My name is Rick Inlet. I am the marketing director here at Vitalware, and today's webinar is titled Helping Hospitals Comply with Pricing Transparency Regulations, Hospital Price Index. As always, thank you for taking time out of your schedules to join us. And I just want to cover a few quick housekeeping items for those of you who are new to our webinars. All attendees are on mute by default. And in order to eliminate background noise, we're going to keep things that way. But we do encourage you to interact with our speaker by using the Q&A panel, not the chat panel, but the Q&A panel towards the bottom of your screen. And we have a dedicated portion of today's event that will be for question and answer. So feel free to send your questions across in that Q&A panel, and we will collect them and address as many as we have time for following the presentation. So with that, I will introduce our presenter today, Kerry Martin, the founder of Vitalware. Kerry has been creating solutions for hospitals for a long time and is passionate about making the business of healthcare easier, and he knows a thing or two about hospital price transparency. So with that, Kerry, I will hand it over to you.
Thanks so much. Good morning and good afternoon, everyone. So real quick, the disclaimer, this is a pretty big rule and regulation. There's a lot to it, and you're definitely going to need to involve your compliance officer, chief legal officer. But everything we talk about today is recommendations and opinions by myself and the company, and you definitely need to bring in chief legal officer to make the final call for your organizations. Vitalware is a mid-revenue cycle company. We've been #1 in class in charge master management for the last 2 years. And that's important because we're actually using the backbone of our charge master tool to help us meet the regulatory requirements of this pricing transparency. I'm going to go through quickly just some status on the lawsuit. We just read some of the latest rebuttal by CMS, talk about the final rule and the fact sheet that was published last November, talk about some definitions, and then get into the overall strategy for hospital price index, how we can meet the requirements, provide transparency to patients, but also as much as possible protect the hospital's data. And then also some of the newer things that we're doing with HPI is providing some service package benchmarks that we'll get into. So when the lawsuit was first filed, there was an author that wrote this article that said that potentially in the short term, the judge would actually rule for the hospitals. And that was kind of the stance back in the January and February timeframe. As we all know, June 24th, the judge did make a ruling, and unfortunately the AHA and the hospitals lost out on that ruling. And so it's kind of full steam ahead with regards to the requirements that were handed down to us. So the latest with the lawsuit is CMS, like I said, just gave their rebuttal, and it's really hard to read that document and not think that, you know, for the most part, that we're going to be under this transparency regulation, and that I don't think that the AHA has gained any ground, and that CMS continues to tout the same things in the latest ruling. They want hospitals to be transparent. They feel it's fair to the patients. And even our compliance officer, Jennifer Bishop, said it's just hard to argue the stance that CMS is taking. So that's the update for what we know right now with regards to the appeal. When we talk to transparency teams and committees, we really are talking about 3 different requirements. There's the charge master requirement that was the 2019 requirement where all hospitals were supposed to display their charge master. And the newest requirement is an all services component and a shoppable services component. So there is really 3 different displays that are required between the 2 different transparency regulations. Effectively, we're displaying a price list of payer allowed amounts, and we want to be thoughtful about how we do that. We definitely want to make sure that we look at volume. Volume to me is a key component to what do you display and what don't you display. You can't display for one payer or one claim of data and feel good about that. So there needs to be some volume considerations in whatever we display to make sure that there's enough volume that it makes sense. Government payers are off the table. So TRICARE, Workman's Comp, those things weren't mentioned. The standard Medicaid and Medicare, although CMS did just publish, Medicare Advantage is a requirement. So Medicare Advantage plans we do need to display, but the traditional Medicare, Medicaids, and other government payers like TRICARE are not required. Contract modeling data. If you have contract modelers, that may be a good way to accomplish some of this. Most people don't have comprehensive contract modelers. They don't feel good about the modeling data. And so we believe the most streamlined and accurate approach is the 835 data to display the allowed amounts. So 835 data will get us there in the next 4 months, and that's really all we have at this point is 4 months to get to a point where we have something that we can publish out to the internet. As I mentioned, service package benchmarks to me is the long-term critical component to your hospital's viability. If patients start actually shopping you compared to the hospital down the street, you're going to need to know how you compare when it comes to service packages. The requirement is machine readable. That does not mean it's downloadable. We say this all the time. Let's not make it easy on the data miners. If CMS doesn't like what we do, they will just refine the requirements. They'll regulate something else. So a lot of CFOs have said to us over the last few months, you know, this is a homework assignment. We want to get a passing grade, not an A+. And we say this all the time, less is more. Again, we have to feel good about what we're putting up on the internet. We are going to get patient questions about this stuff. They are going to bring in screenshots of what we publish to the internet. So we want to really be thoughtful about what we display as we go through this process. All right, so going through the fact sheet quickly, this was published in November of 2019. The very first component of the fact sheet, requirement for making public all standard charges, all items and services in a machine readable format. It says down at the bottom, CMS believes this information and format is most directly useful for employers, providers, and tool developers who could use this data to create consumer price-friendly transparency tools. Well, this data is also going to be useful and available to other providers, to insurance companies, and to the government. So like I said, we need to be thoughtful. They want us to display our gross charge, our payer-specific negotiated charge, de-identified minimum and maximum charges, and the discounted cash price if we have that for patients that are truly private pay. It talks about in the middle of the screen the service package. The one place where CMS didn't realize charge masters don't have a lot of surgeries in the charge master. So we have interpreted service package to really mean those things that don't live in the charge master, that only live in claims data. And a really good example is colonoscopies, total knees, breast biopsies, etc. So service packages is a separate and distinct component from the individual items and services that live in the charge master. Then we get into the shoppable services component where CMS has come up with 70 specific shoppable services. The hospital is supposed to come up with another 230. There has been some other publications around what happens if we don't provide that many services. And there has been relief to, you know, critical access hospitals or hospitals that just can't get to and feel good about 300 shoppable items. We need to include a plain language description. We need to utilize utilization or volume as a basis for determining this. We need to update it at least once a year, although some hospitals have said I make my major price changes in July. So we are definitely looking at providing this and spinning this data up a couple of times a year to our hospitals, because Again, you can't feel good about the data if you make major price changes in July and for 6 months, it's not reflective of your typical gross charges. So I want to level set on some key terms. So gross charges to us means either the CDM price or the total claim charge. Payer-specific negotiated charges, we know that really doesn't exist in the industry, that most hospitals charge the same to all different payers. So we have interpreted that to mean negotiated allowed amounts. The discounted cash price, again, a private pay patient, we've heard anywhere from 10 to 40% is the typical discount off of the gross charge. The de-identified mins and max are really the minimum allowed amount and maximum allowed amount across all of your payer and plans. Service packages are single instance claims. We say a vanilla claim, a run-of-the-mill claim. We do not want the colonoscopy where the physician accidentally punctured the colon and takes the patient to emergency surgery. Those kinds of claims would be off the table for us. We're looking for a plain Jane cardiac cath, colonoscopy, total knee, or breast biopsy. Those are the examples we use in all our presentations, but it's got to be just kind of a standard service that's provided by your hospital. And again, machine readable is not downloadable. Let's not make this easy for the data miners. We use the JSON format, but there are several ways that we can actually make the file machine readable and meet that requirement. All right, we know that there is a penalty if you don't do this. We've talked to CFOs that are in the midst of acquisitions. They're in the midst of negotiating with payers. To me, display what you can and put a disclaimer out there that says, this is what we feel good about on January 1st. You can add more to it later. But to me, the $300 a day is a pretty hefty penalty. But more importantly, there's the concept of a written notice. Okay, we can handle that. Then there's a corrective action plan, which to me sounds like an integrity agreement. And then there's the potential of CMS actually publicizing hospitals that are not complying with this transparency regulation. So there's the monetary penalty, but there's also some things from a PR perspective that actually could be a lot worse for your hospital. So getting into the version 2, again, our version 1 was just displaying the charge master. We did that for 150 or 160 hospitals in 2019. We're now addressing the all services and shoppable services component with this new version. We are bringing together a lot of data from a lot of different sources. So first and foremost, we're going to use claims data. We need to find that highest priced total knee, that lowest priced total knee, and then all the total knees together as an average gross charge. We want to display the high price and the low price claim. That's patient education. We want to include the drugs, the supplies, the anesthesia, and the recovery in those. With a total knee, we would also include some bone screws. We would include the device itself. We would include the blood draw, the CBC, the knee x-rays, etc. And I'll get into how we do that. But that's how we're determining our service packages, is really with claims data. Then we go over and we get the CDM. We need the revenue and usage. We need to determine the individual items and services that are coming from the CDM for that component of the requirement for all services. We have a professional team that will help with determining shoppable services. Again, using volume is a super important component for all of the decisions you make around transparency. Volume has to be a part of that discussion. We need to grab the de-identified mins and maxes across all of our payers based on allowed amounts. We are going to provide a complete back-end system. You have complete control over every field of data, over what gets published and what is not published. You can make those decisions on a daily basis. Our system will actually publish every night the newest file. So if you make some changes today, hit the publish button. By tomorrow morning, that's what we'll displaying for you. And like I said, I think the most important thing is the service packages and benchmarking the total knee, the breast biopsy, the colonoscopies, etc., compared to a couple competitor hospitals that you have in your own town or down the street or in the next town. This is our inpatient shoppable list as it was given to us by CMS. The very first thing that we identified was labor and delivery, and C-sections were actually on the outpatient list, so we brought those over to the inpatient list. We're pretty sure we don't send C-sections home on the same day. The other thing we noticed is that they said 470 is something they want to be a part of the shoppable list. Well, 470 is a joint replacement for lower extremity. So everything from the hip clear to the ankle. We have decided that it's best for patients to break that out. Break out the hips, the knees, the ankles separately, and we're going to do that with ICD-10 PCS codes coming from the claims data. When we get to the outpatient shoppable list, and again, lots of room for interpretation here. CMS gave us one code, biopsy of the esophagus, stomach, and small intestine, the 43239 code. There's 9 other codes in that family, and we can't expect patients to technically select one CPT code versus another. So we have decided to group these families together because we think it's patient friendly, it makes it more shoppable, and it creates some camouflage for our hospitals because we're really bringing a lot of claims data together for the biopsy of the esophagus, stomach, and or small intestine. Like I said, we can't expect the patients to technically know the differences between one CPT code and the next. We're not going to list out all those 10 CPT codes separately and try to gather data separately for each one of those because we won't have the volume we need to feel good about the data. So we're bringing data together in the outpatient shoppable list, and in the inpatient, we tend to be breaking it apart because we just feel that's what's fair for patients. We are creating technical, good patient education information. We've hired a technical writer. We want patients to understand that different doctors take different times in the operating room, different doctors use different implants, and all of those things ultimately affect the gross charge. So that's our patient education component that we're including with this service. We want all hospitals to use it. We're going to give it away to all 950 of our hospitals because we really think if we're going to have a smarter patient consumer, we've got to educate them. And the number one education is not all total knees are the same. This is our HPI 1.0. We displayed the code, description, and amount. Some hospitals chose that they didn't want us to display the code. Completely a choice within our tool of what fields of data you display. We did genericize the descriptions, so we took out trademark names, drug names, we took out cannulated screws with the exact sizes because we found out that those descriptions were actually very Google friendly. And we didn't want your patients to be able to go grab a description and do a search and find a wholesale house as to how much cannulated screws are costing the hospital. So in our first version, we were thinking about how do we protect the data, and with regards to chargemaster descriptions, it was to genericize and quote, make them more patient friendly. You see your hospital's name, you see that it's searchable, you see your hospital's logo. Those are all components that are a part of the display for this first version we did back in 2019. When we go to the shoppable tab, and not all of our clients are using the shoppable tab, we have it available. Some hospitals are actually doing estimates, which is great, but this is our shoppable tab where we're displaying the components of the shoppable list that CMS gave us along with the other 230 items. The first thing the patient has to do is they have to pick a plan. They cannot see all of the different plans at the same time. We're only displaying one column. One of our hospitals said, well, Carrie, I want you to make it a search. They have to search for something before we actually display anything. So we've made that change in the tool and definitely have the ability to start typing the word biopsy or start typing the word knee and up comes the list of choices, and they select one choice and they get that piece of information. So again, that protects data from data mining. You will also see in our billing codes, we're using ranges of CPT codes. We did not want this to be searchable by CPT code. We didn't want to display all CPT codes. So we chose to use ranges of CPT codes rather than comma, 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 and list out every one, because again, it creates a little bit of camouflage and not every CPT code is searchable. So that was important to us as well. If you look at the first three columns of data, those first three columns are actually charge amounts. The gross charge is the average gross charge for that item, whether it's coming from the CDM or from claims data. The low and high price are the lowest claim we found for that total knee, highest claim we found for that total knee. The next three columns, even though it says charge, the next three columns are actually allowed amounts. So we have the Blue Cross PPO allowed amount, the minimum allowed amount across all my payers, and the maximum de-identified allowed amount across all my payers. So those are the 6 columns that we'll display. Again, search first and only get one thing rather than just starting to display the price list. And that idea came from one of our large clients on the East Coast. This can be the display. The shoppable items can be the same display for all services. Another one of our large hospitals said, no, Carrie, I want to follow the letter of the law. It says make it machine readable. I want it to be really machine readable. And so I said, you mean like this? And they said, yes. If that's machine readable, that's how I want it to display. Some hospitals don't want to do this. They want to just display it in a human readable format rather than purely machine readable. We do have a disclaimer at the top that says all services display in machine readable format, not intended for patient use. They still have to pick the plan. They are only going to get so many line items on the screen at any given time. It will paginate 25 lines per. So we are, again, doing things that we can do to keep the data miners from completely just grabbing data and building a database with it. So let me talk about building the service packages. So this has taken a lot of thought. Thank goodness we have Jennifer Bishop, our VP of Coding Compliance, who has been thinking about this since last November. But she decided that we would use a threshold. How many times do we see these codes on this total knee procedure? So we always are going to see the joint device. We're always going to see a recovery. We're going to see some unspecified drugs and sterile supplies. We're probably going to see the knee x-ray. We're going to see the blood draw with the CBC. We're going to see the fentanyl, and we're going to see the joint replacement procedure itself. So we've decided 75% is our threshold. If hospitals say, you know, that's too much information, we want to do 80% as a threshold or 85%, this is the number that your hospitals get to choose. Look at the data and maybe choose a different threshold. But right now, that's what we're doing, is choosing 75%. In the lower right-hand corner, $49,000. If this was the highest price claim of all knee procedures we've seen in the last year, that would go in the high column. If maybe $32,000 was the low claim we saw of all procedures, that would go in the low column. And then the average of our 25, 30, 15 total knees would go into that average gross charge column. Okay, so now we've taken data from the charge master, we've taken data from claims, and now we load it into our tool. We have unlimited columns, so we could have 50 columns of payer plan data. We could have 100 columns of payer plan data. It's one of the reasons we're using the charge master tool as the backbone for delivering this. You can see we have publish buttons right up above the descriptions of that biopsy large intestine. We have a numbering system, O for outpatient, I for inpatient, and P for professional charges, because we are required on employed physicians to list that out. Now, most hospitals say they bill under a separate tax ID, and most hospitals are forgoing the professional charges in round one. So again, we're supposed to display professional charges if the physicians are employed, but there wasn't very much clarity around what if I bill under a separate tax ID or on the separate billing forms, etc. So like I said, most hospitals are interpreting that as I'm just not going to do the professional charges. If you feel you need to do professional charges, you need to list it separately. You don't want to display professional charges for your hospital combined in with the procedure, and other hospitals don't have those employed physicians, because then the patients are really getting apples to oranges. You see the billing description, the very first code is what we call the parent code. Then we see all the components, the non-specific drugs, the supplies, the anesthesia, the recovery. All those components live right underneath the parent code. You see all the billing codes that were incorporated in that family of codes. You see the average charge, the discounted cash price, the gross low charge, lowest price claim, the gross high, highest price claim, the Blue Cross PPO, the identifieds, and then again, imagine off to the right as many columns as you need to store all of the data. Okay, so now we've got the data loaded, we need to start doing some litmus tests. We need to look at the CDM price as compared to what ends up on claims. So we stack the CDM price right next to the average gross charge coming from claims data and make sure that those numbers are within a threshold of 10 or so percent, plus or minus. We want to make sure that if there's things living in the CDM, potentially they should be a service package, not an individual item. So we also need to look and check for that. But this is a litmus test that says, here's what my CDM price is, here's the volume I have in my CDM, and here's the data as far as an average gross charge coming from claims. So that's when we're doing the singles. Then we get to the service packages. So you can see the service package. The very first one is a drainage of a breast cyst. You can see the code associated is 19,000. It is a package. The one in the all services column says publish this. The 0 says don't publish it. So our system knows what to publish or not publish based on 0s and 1s. So we're going to store the data for all those components that are a part of that parent code, that drainage of the breast cyst, but we're not going to publish that data. If CMS comes back in a year and says, nope, we want to see all of those components, or if you go look at the CMS website and you see examples where the components are listed, all you have to do is change those to 1, and now they're going to be listed. You can see we've looked at volume. You can see we have a gross charge price, the mins and maxes. Then we get to all the allowed amount columns. If there is no data in the allowed amount column, we either didn't have enough data or we didn't have any data. So again, if you don't have data for allowed amounts, you can't display it. You don't want to display data if you've got less than 12 claims that's making up that average allowed amount. So that's kind of the second part of looking at the individual items and services, and now the service packages. So now we've taken the data from CMS, we've taken all that SAF data. It is second quarter 2019 through the first quarter of 2020. And we've now used that same 75% threshold. We've built service packages around all of these different things that we call service packages. And now we're going to display for you at least 2 competitors, up to 2 competitors that have those same service packages based on that CMS claims data. So this data is real data. You can see the biopsy of the large intestine in the second display. This particular hospital has a $9,300 average gross price for that colonoscopy. You can see the hospital in the same town is at $7,500, and the hospital that's about 35 miles away is at $6,500. So this is, to me, one of the most important things we can do for hospitals to really get them ready for transparency, is to start putting together these benchmarks in a thoughtful way that helps you decide, do you need to make some adjustments? Because if patients truly do start shopping, then this hospital could lose quite a few colonoscopies because of the difference in price, be it $1,800 from the hospital down the street, or even more than that, the hospital that's 35 miles away. Our system also has always had the ability to upload fee schedules. So if some of your reimbursement from payers is coming through lab fee schedules, maybe 125% of Medicare, or the PT, OT services are provided or reimbursed by fee schedule, we actually, for those different CPT codes, we can bring that data in as well. So our system really is collating the data from the CDM, from claims, from 835s, and from potentially fee schedules that the payer has given us for certain ranges of CPT codes. Everything, like I said, is managed within our tool. You can use our workflow tool. You can have people sign off on these packages that are in those particular departments, or you can click on any line item or multiple line items and do a multi-edit. You can change everything to zeros and nothing will publish out to the website. You can say, I feel good about these 20 service packages. Great, let's publish those. Tomorrow we'll publish another 20. Whatever the situation is, you have complete control over what gets published and all of the fields that you can edit on the right-hand side when you click on a given line item. So lots of ways to also use Excel, make modifications in Excel, and import this data into the tool so that you just have the visibility, the filtering capability. So lots of flexibility in how this data gets managed, manipulated, and published out to the public website. As far as data requirements, 1 year of claims data. We have had many interesting conversations around COVID and whether or not there's going to be a little bit of skewing of the data during those months. But 1 year of claims data, 1 year of remittance data. We have built the service packages based on claims data, but we will validate the service packages. There's also not a lot of C-sections and labor and delivery in the CMS data, so we do have some service packages that we have to build based on the fact that CMS doesn't have a complete listing of what we need for these service packages. Contract modeling data and fee schedule information. Again, if you don't have contract modeling data, we'll use the 835s. If you feel really good about contract modeling data for some of your payers and not others, we can mix and match. We will need the charge master and the fee schedules. We'll need revenue and usage for sure. And for the professional or the physicians, we'll need that professional charge master. All right. So last thing I'm going to show you is just kind of the selection process. What determines the all services? So again, it's a portion of claims, it's a portion of your CDM. I'm going to go through the CDM selection process and then show you how we augment that with the claims process. All right, so first and foremost, we have been doing ChargeMaster work for almost 10 years as Vitalware. We have always purchased the CMS, what they used to call the MedPAR file, they now call the standard analytics file. We sign a data use agreement with CMS that says we will not display any data unless there's 11 or greater. So if there's a hospital down the street that we want to show a benchmark of CT of the head with or without dye, well, that CT procedure of the hospital down the street has only done 9 of them. We are not allowed to show that to other hospitals. So that data use agreement, and the reason behind that CMS says is potential patient identification. So we are going to use the same criteria that CMS uses with regards to how we use their claims data, and we're going to use that when we decide what's the volume that makes sense for us to display. So as we go through the selection process, following the CMS guidelines around volume, we're going to say there's 7,800 line items in our charge master. We don't want to display all of those line items. We're going to get rid of anything that is less than 11. So when I go through that filtering criteria, I now am down to 4,390 lines from my charge master. We don't contract with payers for suture kits and needles and a lot of different things that are supplies and drugs that don't have HCPCS codes. So we believe this is a HCPCS CPT code exercise. We're going to get rid of anything that doesn't have a CPT or HCPCS on it because we just don't contract with payers for those individual supply items. So I'm going to get rid of all the things that don't have HCPCS line items, and I'm down to 2,575. Now we need to look at, do I have replication in my charge master? It is not patient friendly to show 3 line items in the charge master with all the same CPT code and different prices. So when we pivot table on the CPT HCPCS codes, on the left-hand side, you can see a third of the way down, 10060. You can see 3 different prices. We want to take those 3 different prices and average it. So on the right-hand side, you can see the 10060 is now sitting with a $378 price. We now need to lay this down next to our claims data and say, does our 10060 come in at around $378? Is it closer to the 420 that we see in the charge master? But it is now time for us to do yet another litmus test on how does our charge master pricing look as compared to our claims data. So we do that, and we can see that second line item down, the incision and drainage code for abscess 10060. I'm seeing a price in the CDM of 420. Yep, I remember seeing that. And I have outpatient usage of 25, but my Medicare average claim price is $557. So what that tells me is I don't really want to put the 420 price or the 378 price in my average gross charge. I really want to use the claim price because that's what patients are going to see when they get a remittance advice back or they get an EOB back from their payer. They're going to see the 557. The 557 is probably $130 worth of sterile tray or suture kits or scalpel or combination thereof. So because I have an average price of 557 in the charge master, it's living at 420. I decided right there that even though that code lives in the charge master, I need to use the claims data and create or make that a service package. So that's the criteria that we're going through in determining what lives in the all services component and what lives in the individual single items that's coming specifically from the charge master. All right, so recommendations, as I said at the beginning, the compliance officer, chief legal officer has definitely got a big role in deciding the rules and regulations. I've said there's many CFOs that said that they want to get a passing grade. They don't want to get an A+ in this exercise, but there's a fine line to walk as to what are the requirements, what do they say. You know, it says in the regulation, payer plan in a specific column or tab. So I have talked to some hospitals that say, I don't have enough data in my individual plans, especially my smaller ones. I'm going to lump that all together into a single column. I'm going to call it other commercial payers. Okay, it's a strategy. It works. It's something, but the regulation is very specific about those columns of data being very specific to payer and plans. So form that transparency committee, review your charge master, look at benchmark reports for your 2-view chest x-ray, your CT of the head with or without dye. You need to look at, have you negotiated lately? Do you have good data? We just talked to some hospitals that just went online with some new negotiated rates with their payers that they won't have really good data and probably till the end of October or November because they went live May 1. Definitely look at policies and processes. Patients are going to bring screenshots in. They're going to say, you said it was going to be this. Look at right on your screenshot, and I was charged so much more than that. We're going to have to review the disclaimers and make sure the language is correct. We can help you with those shoppable services, but you need to use volume to determine if there's enough data to make this a shoppable item. Those are the main recommendations. This is a pretty heavy lift for hospitals, and like I said, there's got to be a lot of thought that gets put into it. To me, the easiest thing to do is display as much data as you're comfortable with, but make sure that you feel good about the data you're displaying. Like I said, with our tool, you can take and publish one day, feel good about more data the next day and publish some more. Feel good about more data in the next month and publish more. We have one hospital CFO, like I said, that's in the midst of acquisitions and renegotiations, and he thinks he's just going to display the first 3 columns of data, the average gross, the low, and the high, and he's not going to show any payer information until he gets through these negotiations and has enough data to feel good about displaying that. So he said it may take me until May or March to get to the point where I feel good about the data that I'm going to put up. We say this in almost every presentation. Once you let these horses out of the barn, they're never coming back in. This data is going to be out and available. Google is going to have it indexed and searchable within 48 hours. So definitely be thoughtful in the way that you go about this to display this data. And with that, I am sure at least maybe somebody's got a question or two.
Yeah, thanks, Kerry. So there was one question that came in, and I will read that off in just a moment here, but just quickly wanted to address everyone in the audience. If there are any other questions, we are now entering the Q&A portion of the event, so please type them into the Q&A window, and we will address them as they come in. So, Kerry, right now there is one question that came through, and the question reads, what is your opinion on the necessity to publish self-pay package prices, noting that these are different than our self-pay discount, in order to maintain compliance with the transparency regulations? And then there's kind of a part B, which is, would these also be considered a standard charge or a discounted cash price, which they define as the charge that applies to an individual who pays cash or the cash equivalent for a hospital item or service? So long-winded question. Let me know if you want me to reread it for you.
No, I'm good. I brought it up myself. So first and foremost, what the government wants is you to publish out your cash discount price. A lot of hospitals have asked us, does that mean your uninsured person who can't pay? No, this is just somebody that says maybe they have insurance, but they just want to pay. Maybe they have a health savings account, but they're not going to dip into that because this is maybe just a diagnostic procedure. So it is really, most hospitals have said, I give a cash discount. If patients say they're not going to file insurance, I give a cash discount to those people of 25%. So I think the government's just looking for one cash discounted price, but it's really not the uninsured or the person that can't pay that falls into that category of donating or giving away the service. So I think that most hospitals kind of have this concept of, yes, if I just have a cash discount for patients paying cash, then this would be 25% off of my gross.
Great. Next question is this applicable to point of care lab tests?
So if you're using an outside lab, this really doesn't apply. I know a lot of hospitals have negotiated with labs a different price, but for the most part, this is a hospital regulation. So I would only be publishing the labs that you're doing in your hospital, not if you're sending them out to a reference lab or something else where you've got some negotiated rate with that lab.
Okay, next question. I've been reading discussion that the penalty is to increase. What can Vitalware share on our interpretation on the recent newscasts related to this potential penalty increase?
Yeah, I think that CMS will probably increase if a lot of hospitals take the tact that they're going to just consume the penalty and not publish this information. I think it will increase. I think that $9,000 a month is a pretty hefty penalty already, but I would not dismiss the fact that CMS, If a lot of hospitals go the route of not publishing this information, then you will see the prices increase, and you'll definitely see that the website that CMS tells the world who isn't complying with this. Both of those things I think will happen.
Okay, and then our last question that we've got here right now is, how do you recommend to make CDM descriptions for drugs and supplies to be somewhat generic without vendor terms or numbers?
Yeah, so remember, I'm not proposing that we change the description in the charge master. I'm proposing that we augment those descriptions with a new patient-friendly description, and that we say this is an anti-nausea drug or suppository. I don't want to change your charge master descriptions that your technicians and people that use the charge master depend on, but we would publish a more patient-friendly description. So in column B, we would have the description. In column C, behind the scenes, we would have the patient-friendly description, and it's column C that we would publish out to the internet. So again, we're removing trademark names, we're removing drug names, we're removing even quantities, right? 50 milligrams versus 25. We want to completely genericize and just say this drug is for this reason or that reason, and leave all of those quantities, sizes, etc. off that description, because again, it camouflages your charge master data, and the charge master, as we learned 2 years ago, is not very helpful in patients using it and trying to make healthcare decisions.
Great. Well, that takes care of all the questions that we had in the Q&A box here. So thank you, Kerry.
Sure, absolutely.
So thanks everyone for joining us today. That is going to conclude our presentation. Hope you enjoyed it and found it informative. We'll be posting a recording of the presentation along with a copy of Kerry's deck to the webinar page on our site this afternoon. We will share a link with you to that page as soon as those items have been uploaded and made available for you, probably within the next few hours. If you would like more information on anything you saw or heard today, feel free to reach out to your Vitalware account manager, or you could always chat or schedule a demo with us on our website, vitalware.com. And don't forget to follow us on our social media handles on LinkedIn and Facebook to stay informed of future webinars and to catch our latest and greatest content. So thanks again, everyone, for joining, and have a great day.
Thanks, everyone.